Excellent. So that's the recording started again. Welcome back, everyone. So the next session, we're very excited, is from the NIHR Exeter Clinical Research Facility. And we're going to have a presentation from Bea Knight first, and then from Maggie Shepherd. So I'll just hand over to Bea to kick things off.
Thank you, Gordon. My name is Beatrice Knight, and I work down in the Exeter Clinical Research Facility. And I'm a research midwife and nurse. And today we would like to show what we think was research treasures that were, and I'm sure you might be thinking, how can you save research treasures from a bin? But hopefully I'll explain as we go along about one of our particular treasures down in the CRF. You may all remember this when the tsunami that was COVID-19 first hit in March 2021. Our routine landscape, research landscape, changed overnight. Everything came to a standstill. The place was unrecognisable. All research projects, both in our trust down in Exeter, but all over the country, needed to be risk assessed. Some needed to stop immediately. Some needed to continue because stopping the particular project could risk the safety of existing participants. So no more participants could come in, but the study had to keep going. Or some could continue if aligned to ongoing clinical care. One of our little jewels is a thing called the Royal Devon and Exeter Tissue Bank. This was set up about 15 years ago to collect spare or leftover sample material to be taken during routine clinical practice, which was allowed to be saved and used for research. So, yippee, we could keep going. Now, as the COVID-19 screening increased, positive numbers increased. So for those of you who are not really familiar with the process, normally when a sample is taken in hospital, blood sample, spit sample, it's sent off to the lab to be analysed. They do the routine test, and then anything that's left is flung in a bin. Now, it's a very special bin that gets sent off to be incinerated, but it's a bin nevertheless. With the COVID positive samples, the scenario changed slightly. So we were taking the samples, they were sent off for analysis, and rather being put in the bin, they were being temporarily saved. Now, part of the reason for temporarily saving them was everything was happening at such a pace. This was a new virus, so they needed to keep the samples so that they could retest them. They could help validate, let's make sure they work, new technologies, because with the speed of everything that was happening, in order to keep pace, they had to develop new technologies for screening that were more complex, but they could be speedier and they could use larger volumes. They could screen larger volumes of samples at the same time. So there was a resource that was being saved that had the potential. There were leftovers. They were from routine care. So there was the potential they could be used for research. However, although they were going to be binned eventually, we still need donors' permission to use them. So as the tissue bank was one of the studies that was up and running, we identified about 760 COVID positive individuals that we could follow up between about April and March this year. We managed to contact 557 directly. That was either by telephone, by email, by post, and an overwhelming 75% agreed that we could keep these and use these samples as a research resource. The majority were saying things like, why do you even need to ask? But it gets back to that bit. Even though it's in the bin, it's still yours, and you need your permission to use them. So we set up the Exeter COVID-19 sequencing project, known as EXCOSE. So these samples not only were we given permission to use the samples, we also were given permission to access people's medical records, which provided extra information that perhaps some of the other more public health, everybody in projects didn't have. So working with the National COVID-19 Genomics Consortium, we inputted and helped to explore the virus's genetic codes, identify how it might be changing as it was spreading, This information was essential to help us develop prevention and containment strategies, also to develop new and refined analysis tools, and to understand how to treat and care for these infected. So we inputted, together with hospitals all over the country, we inputted into this national genomics consortium work. Locally, we were able to study looking at the patient staff location movements within the hospital led to an understanding of hospital transmission of COVID. We were able to identify hotspots leading to improvements in hospital infection control policies. One of the things we discovered was there was a lot of staff-to-staff transmission. It was that thing about we were very, very careful about looking after people and trying to protect us from patients and making sure there was no infection there, but there was perhaps less stringent when people were going in for coffee or when they were all together at lunch. So that identified it, and we helped change in hospital infection control policies. We also use these samples to validate, which means to show that it works, a new test for quantifying active viral load. So again, in the early days, there was a lot of problems with people being sent out to care homes that were asymptomatic. So they sent them out to care homes, get them out the hospital, but actually they were infected. So this active viral load is really a way of saying how infectious you are. So you could be positive, still have a positive swab, but if your viral load is very low, you're unlikely to spread that infection to anyone else. For our very small research team, some of the team, there's 4 of us, and mainly 4 of us, they were on from some of their other studies. They were borrowed from other studies that had been sorry, when I get excited, my words run into each other. Some of our staff were deployed from their usual jobs. Especially at the beginning, we did an awful lot of listening, lots of listening. People just needed their story to be heard. Being part of the research experience, they felt listened to when it was always very new and new symptoms were emerging. We had people that were completely stunned. They couldn't get over how much of an impact this infection had. We had other members of staff who were completely symptom-free, and they only were tested because they were testing everyone in the ward. So they came into work thinking they were fine and get sent home again with no symptoms whatsoever. So that was very distressing for them too. We also had, on this feedback from patients, there was recurring themes. People were scared. It attacked my lungs and took everything away from me whilst I was poorly. I'm still having panic attacks when I'm trying to do my shopping. People were isolated. I couldn't drive for weeks after. I was in such a daze. I wasn't myself. It just wasn't right. And worried about the future. My confidence has been shattered by fears over losing more than my independence from COVID-19. So within the national and the scientific and all the scientific and the actual preventing and treating the virus, there was an opportunity for patients, especially in those early days, when it was scary, it was frightening, and nobody really knew what they were going to do. So we gained a good insight, but also enabled people to talk to us, and they did. They talked to us often. So it's only a brief overview I've given of one particular area of research we did down in Exeter. So I think in terms of, I know Gordon has said, I'm intrigued by the title. So I hope I've given you an idea that research treasures can be saved from the bin. And in terms of expose, we certainly think so. Thank you for listening to me.
Marvelous.
I would just like to acknowledge. So I would just like to acknowledge all the participants, our expose team, the NIHR and the COG UK team. We've all been working together, as we all have in this past incredible year.
Marvelous. Thank you. Thank you so much, Pia. And I think the fact that you identified that there was a really useful source of information there that was about, well, obviously it was being kept in terms of the COVID patients, and actually using that for really to help to sort of feed into the wider conversation, and also the increase in understanding of the genomic situation in terms of COVID, I think is really fantastic. And I was really struck by how you said that people were so willing to participate, and obviously overwhelming number wanted to help. And I think we heard earlier on today from the group in Southampton about how people just want to help. You know, they want to help out in any way they can, and I think across the whole country, and anywhere you speak, people just want to have realised that they have information, be it whether they have had COVID or not, that they just want to help out in any way possible. But I'm interested. Sorry, you're going to say something there, B.
One of the things that was recurring was when we were saying, yes, of course, Kate, is there anything else I can do? Is there anything else I can help with? Can I give you more bloods? And within the confines of the project, we were working within our ethical, what our remit is, but it was that point of people that just wanted, is there anything I can do?
Mm-hmm. And also, I was struck by, you know, the kind of qualitative aspects of the information that you gathered as well, and you know, and even just having somebody to speak to about how they were feeling, because I think for all of us, you know, I remember speaking to someone relatively recently about how I was in the middle of Sainsbury's, and I was suddenly struck by how bizarre the situation was, how everyone was wearing masks, and you know, the hesitancy about too near each other, and thinking back how different that world is to what we've been used to, you know. And it's I guess if you have had COVID, I've been fortunate I haven't had COVID myself, but if you know, the anxiety that could be associated with that must just be sometimes overwhelming.
One of the decisions we made at the early, we had a small team of which a certain proportion, there was 3 of us, there were clinicians, 2 nurses, and 3 nurses at one point, and a medic who was isolating, she couldn't go over to the wards. But we made a decision that had to be a clinician that was phoning people and contacting people, just because there was that need for it was something unexpected. We didn't want administrative staff or any maybe junior staff contacting people, because this was something that was unknown, and that was part of a nurse's skill, is that you do deal with unknown, you allay people's fears. How many times in a clinical situation when someone they're anxious about a diagnosis, or they're not sure what the tests are going to say, clinicians are used to dealing with that kind of uncertainty, and that even although this was completely uncertain, there was core skills that nursing staff have that are able to deal with that level of uncertainty from a participant or a patient.
Yeah, no, I completely agree with you, because really when you've got somebody in front of you, you've absolutely no idea what they're going to say. So that ability to kind of react in a positive way as much as possible when somebody's saying something to you that could be you know, quite distressing or unexpected, I think is a real skill that nurses have. And then in terms, you said you're a research midwife as well. Is it the midwifery research that was that how's that been over the last year or so?
The main projects were the national ones, the public health, in effect, the monitoring data, and everybody that was pregnant. There would have been people that I think we gained an awful lot of pregnancy data on COVID and vaccines, because as it started, people were pregnant at the time everything started. So you were getting almost unexpected data, because and one of the things that I noticed as a clinical that completely changed the landscape. Midwives, all of us are very compassionate people, but midwives are more touchy-feely, huggy people. Come to me, and that all stopped. We couldn't do home visits. We couldn't do the only face-to-face visits were at the time of a routine scan. So we were trying to get as much detail as we could at the 2 routine scan points. So whereas women, it had a big impact on mothers, because normally they have access, they can pop into a clinic, you can see your midwife comes to the house. So many things were curtailed, and it really impacted.
Yeah, and I think the therapeutic benefits of, you know, the tactile nature of midwifery, it must be so difficult to kind of step away from that and almost sort of having to tie your hands behind your back, you know.
But with nurses too, instinctively you want to hold somebody's hand, you want to hug them, you want to sit with them. And when it's through the barrier of they've got gloves, you've got gloves, it just instinctively was not right. And I think that impacted in a lot of staff. You were so busy doing what you had to do and making sure everything was safe, but there were the fundamental things that make you as a nurse, that impacted on us as clinicians, all the things you couldn't, someone's in tears, you instinctively want to go, cup of tea, come and have a hug.
No.
You just couldn't.
Yeah.
And communication is essential.
Yeah, and I think people have become astute to sort of look at people's eyes and see whether they're happy, or you know, because you can tell even when somebody's got a mask on, you can still tell when they're smiling, you know, and so forth. So no, thank you very much for that, Bea. Thank you.
Okay.
So Maggie, have you got your presentation there as well? Maggie? Oh, let me see if I can. Jen, oh, there's Maggie. Asked her unmute.
Thank you. Sorry, it was saying
there we are.
Let me unmute myself. I'm just going to share my screen.
Thank you.
So thank you for the opportunity to talk to you this afternoon. So I'm going to deviate away from COVID-19 for the next few minutes and really talk to you about some of my work that I've been doing within my NIHR 70 at 70 role. And it's been great to see some other 70 at 70 colleagues on the call over the last couple of days. I'm going to tell you about some strategies that we developed really to bridge that perceived gap between research and clinical care, and how these strategies were used to increase the awareness and engagement in clinical research amongst our colleagues working in clinical areas. So I don't need to explain to this audience that we're well aware that research active hospitals result in better patient outcomes. And in fact, those improvements in healthcare are known to be associated with greater staff engagement in research. So clearly getting staff engaged in research is the key element within this. But also there's evidence to show that there's barriers to research. Now this could be inadequate knowledge or training, but also there's a perception that research may be seen as a specialist activity and something separate from clinical care. And that's something that I thought was really important to address. I'm also really aware that the support for nurses doing independent research and sustaining clinical academic careers really remains challenging. So within my remit as a 70 at 70 senior nurse research leader, I was keen to introduce some new initiatives that may help support clinical academic careers. So just for those of you who may not be familiar with the 70 at 70 role, this programme provides some dedicated time, 2 days a week over 3 years, for us to increase clinical academic opportunities for nurses, foster a research culture, and really try and embed the perspectives of nurses and midwives in terms of influencing the research that can be done. So what I'll be talking to you about this afternoon is just 3 initiatives that I've developed over the last couple of years, really to increase clinical staff engagement in research in our organisation. So what I was aiming to do is specifically develop some new initiatives to facilitate clinical research opportunities, both for patients and staff, and bridge that gap between clinical care and research. So I'll be talking to you about 3 different initiatives this afternoon. Our Chief Nurse Research Fellow Scheme. Now this is based on the model that's been used elsewhere in the UK of Chief Nurse Fellows, which often focus on clinical expertise and education, developing new clinical skills. So we just tweaked that model to really focus on research. So these Chief Nurse Fellows, the idea was that these are clinical staff who were seconded out of practice for 1 day a week for 6 months, and they undertook a bespoke training program that we developed. Within that, with the support and mentoring, they were also able to identify local clinical problems that they could start to investigate as a potential project for future research. I'll also be talking to you about our nurse-led embedding research and care unit, or ERIC unit. Now, this model was based on the practice development unit model, which again they'd been beacons within organisations for excellent clinical practice and education, but they hadn't traditionally had a specific research focus. So again, we were taking a model that had been shown to be effective elsewhere and just tweaking it to emphasise the research. And the ERIC unit, really the vision is for that unit to pioneer innovation, evaluation and research participation at all levels within the unit. So all members of staff, whether you're the most junior staff nurse on the ward, if you're a specialist nurse, if you're a physiologist, a dietitian, a pharmacist working in that unit, everybody would have a greater exposure to research. And that unit is supported by a research facilitator. Now that's a new post that we developed here, where we've got a senior research nurse who's able to go in and work in the department and help at all different levels to kind of really flag up the importance of research and how people can get involved. And then the third initiative is setting up a clinical academic network within our organisation for nurses, midwives and allied healthcare professionals, really to provide support, mentoring, networking. And these are individuals who are interested in undertaking independent research and at all different levels of that research journey. So some are just starting up with internships, others have already completed PhDs. So just to give you a little schematic of how these initiatives kind of interconnect with the wider research team. So of course, there's a whole breadth of research support and mentoring that's already available through our research design service, research and development departments, clinical research facilities, etc. We're also setting up some new internships with the Academy of Nursing in Exeter, and then developing this bespoke training package, which is not only for our Chief Nurse Research Fellows, but also can be tapped into by other individuals within the organisation. And we're also very keen that the ERIC unit wasn't just an acute focused emphasis, but also this covered the staff who are working out in the community within that unit as well. So in terms of developing both the Chief Nurse Research Fellow initiative and the ERIC unit, the ERIC Embedding Research and Care model, we really took time to develop this as a consultation process. So first stage was really reviewing the literature, of course. So in terms of the ERIC model, this was looking at the practice development unit literature that was already existing, identifying what had made that a success, what barriers they'd come across, and that helped the initial vision develop. And again, with the Chief Nurse Research Fellows, we were looking at the literature on Chief Nurse Fellows elsewhere. Second stage was really engaging with our Chief Nurse, Deputy Chief Nurse within the organisation. We absolutely wanted their buy-in. And in terms of engaging clinical staff, it was really critical to get them on board and ensure that whatever we were developing was aligned with the corporate strategies for nursing research, but fitting with the quality improvement and patient safety initiatives as well within the organisation. We then moved on to stage 3, and that was consultation with the lead nurses across the organisations, our head of professional development, our research interested practitioners within our clinical academic network. And really this is where we were able to refine the model, look at developing criteria for what would make an ERIC unit and how were we going to implement and evaluate these strategies. The following stage, we were looking at consulting with matrons and clinical research teams across the organisation, highlighting barriers and potential enablers, and really trying to engage staff. And then the final point was kind of launching the ERIC unit and the Chief Nurse Research Fellow initiatives with communication strategy, and interviewing and appointing staff for the Chief Nurse Research Fellow roles, and also appointing the ERIC unit department. So just to give you some results, our first cohort of Chief Nurse Research Fellows have just finished their first 6 months. We started off with 5 healthcare professionals, 2 were community-based, that's 1 community physio, 1 community midwife, and then we had 3 hospital-based nurses, 1 from gastro, 1 from stroke, and 1 from the neonatal unit. And I was able to secure funding to buy them out of their clinical roles with support from the Southwest Clinical Research Network Research Innovation Fund, and also from the Burdett Fund for Nursing. So all the Chief Nurse Research Fellows completed the bespoke training, and with mentoring developed local projects to tackle clinical problems. And that was obviously specific to their clinical areas, but the value of that is that their clinical colleagues could see that what they were learning and what they were developing in terms of research could actually really make a difference within their own practice area. And interestingly, the secondment as a Chief Nurse Research Fellow increased the motivation of these individuals to become clinical academics in the future. And you could see a couple of quotes here from our Chief Nurse Research Fellows about, you know, this was just a start of their journey, if you like. They're going on to seek further research funding to develop a research portfolio and applying for internships. We're going to be interviewing for our next cohort of Chief Nurse Research Fellows in the first week of June, and we've got had 10 expressions of interest for those roles going forward. So we see this as a rolling programme, always having a cohort of Chief Nurse Research Fellows in the organisation. We've changed the model very slightly, so in the next cohort we're going to second them 1 day a fortnight for a year, because this will give them a longer time period to actually develop a project and get something actively going. And that was in response to feedback from our Chief Nurse Research Fellows. We were also very keen to, of course, measure what we were doing. So this is the research spider. You can see the reference at the bottom right hand of the screen here. We got our Chief Nurse Research Fellows to do a self-assessment at the beginning of the fellowship in terms of how much experience and knowledge they had in all these different areas at the start of the programme, with most of them showing kind of no experience or just little experience at the start of the project. And what you can see on the right-hand side is their scores at the end of the secondment, where you can see improvements in experience and knowledge of things, particularly like reviewing the literature, finding relevant literature, applying for research funding, etc., etc. In terms of our embedding research and care unit, so this is a nurse-led initiative, and where we're providing dedicated support from myself, from other senior nurse researchers and a research facilitator, really with the idea of increasing awareness of research amongst all the individuals in that department. And it's our respiratory department that have been awarded the first embedding research and care unit, which is probably quite timely in terms of COVID and how much our colleagues in that department have been involved in research over the last 12 months. So within this initiative, we're promoting research training, and staff within the ERIC unit, within the respiratory department, will be able to tap into the training that we're offering for our Chief Nurse Research Fellows. Our research facilitator is able to assist with study delivery, and our research facilitator, a key role will be helping to identify local priorities for research within the respiratory department from the nurses, from the physios and other colleagues within that department who may have identified clinical problems but may not have realised how they could potentially take that forward into a research problem. So we're really looking to encourage research engagement at all levels, and we'll be measuring and monitoring that throughout the next 12 months. And already 2 of the staff within the ERIC unit have been supported by ourselves to gain external funding within the Research Associate Scheme to develop their own research. And there's a real enthusiasm within staff within the unit to learn. And also we'll be doing the spider assessment with all the staff. We've already sent out that data to be collected on 120 staff from within the ERIC unit, and we'll be doing that again at 12 months' time. In terms of our clinical academic network, as I mentioned, this really provides peer support, mentoring and networking to those interested in undertaking clinical research. There may be some of us who are fortunate enough to work in a very active research environment, but there may be other colleagues within the organisation who they really don't have that support network around them. So part of the ethos of the clinical academic network is to provide that support. So we've got more than 45 nurses, midwives and allied healthcare professionals part of this network, and just over the last 18 months we've had success with personal academic awards for individuals who are part of this network, and we've been able to offer support from others who've already been through that scheme, so they can share their experience of the interviews, of the application process. We're able to offer mock interviews to individuals going through those schemes. So it's really kind of sharing information to help people move further on in their organisation. So to conclude, we felt it was really important that there's not just one approach that's going to work. It's looking at multifaceted approaches to successfully engage people in research at all different levels. But what these approaches have done is really support research training and engagement. They've enabled career development for our colleagues, and again, I'm really interested in innovative roles for staff within the organisation. Embedding research within a clinical career, I think, is hugely important. And these schemes are also helping us identify individuals with potential to undertake clinical academic careers in the future. And I really think these are just small steps to start really transforming and bridging that gap between clinical care and research. And it's provided new opportunities for staff who otherwise wouldn't have been that exposed to research to become engaged in being research active. So I'd just like to thank the Burdett Trust for Nursing and the South West Peninsula CRN Research Innovation Fund for helping fund these schemes, and very happy to take some questions.
Marvellous, thank you so much, Maggie. And it's certainly a perennial problem for many of us about bridging that gap between, you know, the getting research and getting awareness and engagement out with our clinical colleagues. So, yeah, I'm just seeing that there's a couple of comments and questions in the chat there. Fiona Maxton, it says that she loves the way that you've used an established model to develop the ERIC programme. And Deirdre Highland in Ireland has asked, can research nurses avail of these schemes, or is it aimed specifically at clinical ward staff?
Yeah, thank you. Well, thank you, Fiona, first for your comment. I mean, I'm one very much, I don't see the point in reinventing the wheel. If there's something there that's out there and that's working and you can just tweak it, then, you know, that's a great way to go. And Deirdre, yes, so in terms of our, we've got research nurses who are working within the ERIC unit who are undertaking some research of their own anyway. With the bespoke training that we're offering, again, I'm very keen that if I'm offering it for a small group of chief nurse research fellows who come on a regular basis, but if there's other research nurses, for example, we've got some new research nurses joining our department shortly, absolutely we're going to open up that training to them, and they're able to dip in and dip out of whatever suits them. Again, if we're running something that's available for some staff, then the more the merrier as far as I'm concerned. The more people who want to be exposed, the better. I think a lot of the training that we're doing in terms of the chief nurse research fellows is really starting off at a very kind of ground level for individuals who perhaps are not that familiar with research already. But yeah, very keen to, from my perspective, anyone who's interested, very welcome to join in with the initiatives. And I think, you know, these initiatives will just develop and evolve as time goes on. We don't see them as being static.
And it's the kind of ripple effect of this, isn't it, Mia? Because obviously you're then the people that are part of the scheme then go back to their own clinical area and then help to kind of enthuse others as well, isn't it? And it's really great that you've got 10 people who've inquired about joining the next round as well, you know, so that kind of perpetuates the kind of the engagement and hopefully reaches into other areas that perhaps haven't been engaging quite in the same way in the past.
And I just see a couple of other comments in the chat about, is it transferable to other countries? I mean, I'm very happy to share anything that we've done. And again, you know, through discussion, it can be adapted or adopted in different ways. So absolutely very happy to share that. And what we've also done with some of my other 70 at 70 colleagues, we've networked our clinical research, our chief nurse research fellows with, there's other similar schemes in different organisations, perhaps under a slightly different name, or people working as research associates. So we're putting these kind of new interested individuals in touch with other people so they can see what else is going on in other areas. They've been able to network with senior clinical academics through the 70 at 70 scheme. For example, one of the chief nurse research fellows was a midwife. She was able to link in with some of our senior colleagues through the 70 at 70 scheme and see how they've developed their own research. You know, I think that networking and sharing experience and skills is key.
Absolutely, and I said yesterday, it's a real feature of the clinical research and midwife community that everyone's happy to share information that they have, because everyone's been there at the point where they've been looking for something and having to start something from scratch, and nobody wants someone else to reinvent the wheel. And it's about that kind of sharing something with someone else and then getting feedback about how they've used that can help to improve your own situation as well. So I just think that's fabulous. So and I think your Twitter handles on the programme. So Elise, if you want to get a hold of Maggie, you could perhaps reach out to her through Twitter. And also just quickly, it was more of a general comment from Kathy about mentorship. And one of the things that the IACRN does is it offers mentorship from more experienced clinical research nurses. So that might be something that you want to look into, and I'm more than happy to have a chat with you about that, Kathy, if that's something you would like to do.
I was going to say the very thing, Gordon.
There
And
you go.
Kathy presented yesterday beautifully at the, was it yesterday? I can't remember. Maybe it was the day before, a day before in Africa, the Africa chapter. So I think we need to think about all sorts of mentorship and different sorts of mentorship for different things. And this is slightly different, perhaps, what Maggie is doing. And I wanted to thank you, Maggie, for coming, even though we've recently poached Ruth to our national role, but for the greater good, the sacrifice I hope you see. And I think these are discussions with her about how we roll out best practice internationally as well as nationally. So thank you so much for your talk.
Very welcome.
Yeah, thank you very much, Bea and Maggie. That's excellent. Thank you so much. Right, so moving on now, and I see that Sabine's with us at the moment as well. So Sabine is based in Sweden, although she's originally from Austria, and Sabine's doing some fantastic work in Sweden about setting up a network for clinical research nurses there. So I'll just share her presentation just now with sound. Share. Grand. There you are, Sabine. Hi, Sabine.
Hi.
Hi. So can you see the presentation there on your screen? Yeah.
Yes, I can see it.
Marvelous. Okay, I'll just play the presentation, and then if
Okay.
anyone has any questions for you.
Yeah.
Thank you.
So, this week we celebrate clinical research nurses and midwives all over the world. And I would like to give you a short overview on clinical research nursing in Sweden. My name is Sabine, and I'm the chair of the brand new Swedish Clinical Research Nurse Network. We started in March this year, and I'm also in charge of a local and a regional clinical research nurse network, and I'm the coordinator for a national project group who works with professional development issues regarding clinical research nurses. So, if we get started with some facts about Sweden. Cornerstones of the Swedish healthcare system are the principles of need, solidarity, cost effectiveness, and equal access to care, regardless of socioeconomic status or geographic location. This principle is mirrored in the organization of healthcare in Sweden. At 3 independent governmental levels: the national government, the healthcare regions, and a total of 290 municipalities. Overall goals and policies are set at the national level by the Ministry of Health and Social Affairs, while regions are mainly responsible for hospital or inpatient care and primary care, compared to these 290 municipalities who are responsible for nursing home care, social services, and the housing needs of the elderly, as well as care for the physically and intellectually disabled. I think that the UK's world-leading status in research and innovation is in large part founded upon its networks and accessible research and innovation infrastructure. Sweden is a very large country with an extreme low population density compared to the UK. And to get in contact with each other is really frustrating for clinical research nurses. It's really hard. Until March this year, we did not have a national network, and we are still working with mapping local and regional clinical research nurse networks. Our vision for the future is that the national network can provide a forum which enables information exchange, collaboration, knowledge transfer, and the possibility for involvement in consultation and opinion work. The Nordic countries, as you can see on the map, which means Norway, Denmark, Finland, and Sweden, do not have a separate IACRN chapter. This is because we do not have a strong Nordic research infrastructure. In Sweden, we are the first Nordic country who has a national clinical research nurse network. Now we try to contact local network coordinators from other Nordic countries to establish a contact network and to learn from each other. Hopefully, this will lead to an IACRN Nordic chapter in the future. So, how do you become a clinical research nurse in Sweden? One of the basic qualifications and requirements is a degree in nursing. The National Board of Health and Welfare is responsible for the registration and licensing of registered nurses. The license does not have a time limit, meaning that healthcare professionals do not have to reapply to maintain the license. Licensure is applied for by the individual nurse after successfully completing of education and granted without further requirements. Nurse specialists, for example, in surgery or intensive care, do not have a specific licensure. However, the registered nurse title is a protected professional title in Sweden and can only be used by those with particular qualifications. 11 different nurse specialties are considered to have a protected professional title, but clinical research nurses is not one of these protected professional titles. To succeed as a clinical research nurse, you need bedside experience as a registered nurse, at least 2 years, and the GCP certificate. A lot of employers prefer clinical research nurses who have courses in chosen specialty, for example, oncology or cardiology. As I mentioned earlier, has Sweden no certification program nor an advanced academic degree for clinical research nurses. This is on the wish list for the future. Clinical research nurses work in hospitals and other medical facilities, and they work with diverse patient populations. One primary responsibility involving caring for patients, but specific job duties vary depending on employer and specialization. Clinical research nurses assist doctors, provide treatment, administer medication, monitor patient recovery and progress, and educate patients, families, and other clinical professionals. Although we do not have an advanced academic degree in clinical research nurses nor a national competency model, some regions do have locally defined core competencies for clinical research nurses, as you can see here. At my research unit at the University Hospital in Uppsala, we defined a local competency model for clinical research nurses. Professional development as a clinical research nurse is vital to guarantee job satisfaction and job continuity. As an experienced registered nurse, it is difficult to handle the feeling of limited knowledge and expertise as an unexperienced clinical research nurse. It's a new role with other expectations and limitations. An extended period of introduction is necessary to guarantee patient safety and protocol compliance. And for that reason, a project group of experienced clinical research nurses defined an introductory program to help unexperienced clinical research nurses during a 12-month period. The first year as a clinical research nurse is hard, and many times you struggle with the daily assignments, like handle blood samples and the centrifuge, as you can see here. But our wonderful tutors give clinical guidance, and our coaches in reflection groups establish a safe environment to talk with each other. The introductory program also includes practical and web-based courses, lectures, and an introductory day on local regulations and processes. We ran this program as a pilot project under 2020, and we implemented it at the University Hospital this year. As I mentioned earlier, the clinical research nurse is a crucial member of the research team. Clinical research nurses are delivering specialized nursing care, have highly developed skills regarding trial protocols, research ethics, legislative requirements, and so on. But they are also working long working hours, sometimes in isolation and without professional support networks. So the question is, why we do this when it's so difficult? And the answer is because we love what we do, and the clinical research nurse is so diverse and so exciting. And we all are dedicated to improving healthcare through research. So what we wish for the future? For the future of clinical research nursing in Sweden, we are working on a national job description for clinical research nurses, and hopefully we can publish it before summer. The next step will be to work on a national competency model for clinical research nurses. We will have the first national clinical research nurse conference this year, which seems to be a milestone in our work. We hope to get an academic clinical research nurse program with a certification sometime soon, and to improve working conditions for many clinical research nurses in Sweden. We are working for a cultural change in healthcare settings, which makes research part of everyday thinking. And last but not least, we hope that the brand new National Clinical Research Nurse Network can provide an environment for learning and exchange. You're curious, you want to know more? So get in contact with the Swedish Clinical Research Nurse Network. You have my email here. And thank you so much, and have a great International Clinical Trials Day. Hello. This week we celebrate
Hi there, you're muted, Gordon.
I can't hear you.
Sabine.
You really didn't want to hear what I was saying anyway. No, I was just saying thank you so much, and it's another example of how international clinical research nursing is, and so we're really pleased that you're able to join us, and what fabulous work you're doing as well.
Thank you for the opportunity to take part of this.
Great. I see there's some comments. Lael, I think it is, says, is just amazed that there's a 12-month introductory program for new CRNs. It is fantastic. Could you tell us a little bit more about what's involved in that, please?
It's a one-day introductory day with lectures on regulatory requirements, and we do have a GCP course. And we do have a course in handling blood samples. And we do have web-based courses, ethics course, biological samples course, and we do have tutors, mentors, and clinical guidance. So it's bedside clinical guidance and reflectory groups over a 12-month period.
Excellent, thank you. There's a question there from Vicky Adele. I don't know if you can see that, Sabine. It's are there CRN based in most and I can't pronounce that word.
Yeah, I think it's
Sjukhus?
sjukhus, so it's hospitals. So, yeah.
Okay.
Yes, that's right. So you can find clinical research nurses everywhere, in primary care units, at hospitals, at university hospitals. So they are everywhere. But we are not organized. But what we try to get rid of that.
Excellent. Do you have a feel for how many clinical research nurses there are in Sweden?
That's hard to say because at my research unit, I'm in charge of a local network with 140 clinical research nurses at my university hospital. But I know at other hospitals, it's about between 15 and 60 clinical research nurses, depending on the hospital size. So maybe 2,000. I don't
Wow.
know.
Excellent. No, that's fantastic. And it's I think some of the guys, and I guess with the geography of Sweden, people could be physically isolated from
Yeah.
other research nurses as well. So it's a fantastic work that you're doing. And I think Elise Peterson in South Africa is also saying what awesome work you're doing in such a short period of time, and it really huge congratulations to you.
We can't lose time to organize those.
Jean Bruce, are asking the research nurses generally employed by universities or by the hospitals?
We think it's better if they are employed at the hospital because they're the patients. It's really complicated if you are employed at the university because they don't know how to handle patient care. So it's better to be employed, but it's yeah, it's possible, but we do not recommend it.
Yeah, and I think it's been a bit of a debate all over. Well, I know it's been a debate in the UK, and there are some benefits about being employed by universities, but I think in terms of patient access and contracts and so
Insurance
forth,
issues,
absolutely.
yeah.
Marvelous. Well, thank you very much again, Sabine. It's lovely to have you here.
Thank you.
Thank you. Great, so I shall just move on to our next vignettes section. So I'll just get the first video up. And then I'll share my screen. Share sound. Excellent, here we go.
Hi, my name's Graham. I live in Wakefield and I'm a public member of the cardiovascular and the cancer research, patient and public involvement and engagement groups here in Leeds. As a geologist, I've got a scientific background, but not in the medical field. About 6 years ago, my 34-year-old son suffered a heart attack. He was operated on immediately and fortunately made a full recovery. He celebrated his 40th birthday only last week. At the time, I was puzzled how a fit and healthy young man with no other medical problems could suffer a heart attack. I was keen to learn more about research into cardiovascular problems, particularly in the young. I wondered whether it was possible to contribute in some way. A chance conversation during a friend's routine appointment at the clinical research facility at the LGI with a member of staff prompted me to join the cardiovascular PPI group along with my wife Judith, and later I joined the cancer PPI group. It's been fascinating attending PPI group meetings in Leeds and more lately virtually, hearing from key researchers and contributing to discussions about their projects. As a public member, my views have always been listened to and welcomed. I've had the opportunity to meet some wonderful and dedicated people and research professionals and hopefully contribute in a positive way to their projects. Last year, I was invited to join a small group in coordinating the large-scale clinical trials of COVID-19 vaccines in Leeds. It's been really rewarding to think that my contributions may have helped influence the successful rollout of vaccines across the UK that have helped save countless lives.
Excellent. And I think you'll all agree that patient and public involvement in research is hugely important. So it's great
That's
to hear
really
from
lovely.
Lisa.
Yeah, that was a lovely one, wasn't it?
So these are obviously just shorter presentations, so I'll just get the next one. Sorry, I've got lots of screens open at the moment.
Don't share your bank details by mistake.
Again. So the next presentation is from Oxford. And I shall just share my screen now. Sound.
My name is Claudia Hurducaș. I'm the Clinical Research Facility Manager, and I provide the interface between staff on the ground and their team leader and the senior management team. The NIHR Cognitive Health Clinical Research Facility is a dedicated space for delivering experimental medicine trials. The studies run within the Clinical Research Facility are early phase experimental medicine. We have the main unit at the Warneford Hospital in Oxford and a satellite clinic at the Whiteleaf Centre in Aylesbury. It is of special importance as it is the only mental health specific CRF in the country.
My name is Edoardo Stinelli. I work here at the Clinical Research Facility as a specialty doctor in research. My role is to explain to the participant what the research is like, what the specific study is like, as well as collect the consent and making sure they're safe throughout the study.
The Clinical Research Facility is formed of a team of varied staff members, such as research assistant, research facilitators, nurses, research administrators, and nurse cadets.
My name's Ellie. I'm a nurse cadet who works at the CRF. I currently do things like observations, which means taking blood pressure and respiratory rate. I also do bloods, and everyone here is so friendly. It's really good to be a part of research.
A research facilitator may undertake laboratory work and process samples, and our research administrator ensures the interface with the public and participants is always a happy, smiling one. The Clinical Research Facility is the perfect place to undertake invasive procedures as part of clinical trials, such as lumbar punctures undertaken by neurologists, or dispensing of controlled drugs overseen by our pharmacist team. The Clinical Research Facility has been impacted by COVID-19 as much as most other services. We have managed to continue running our clinical trials alongside urgent public health studies. One example of such study is the Novavax trial, which is a vaccine study recruiting 463 participants within Oxford Health. If you'd like to hear more about the research we undertake at the Clinical Research Facility, or if you'd like to take part in one of our studies, or perhaps get involved in our patient and public involvement group, please visit our website.
It is wonderful just to see all the research that's been conducted all over the UK, isn't it? In Ireland,
Yeah.
It's fantastic. It's fantastic.
I like the nurse cadets.
Yeah, that's not something we have up here. Is that? Are there many nurse cadets down in England?
Not that I know of. It's been on my radar just a short time, but it's something I think we need to see about how we can develop that a bit further. There's a scheme through the RCN, but I'm not sure if that's the same as the one they were running.
Let's get the next. And I have to say, being involved in one of the first 5 clinical research facilities, it is hugely gratifying to see how many there are now all over the country. Is it over 60 now? Is that correct?
Over 50 in the CRF network.
Gosh, that's incredible.
That's including Ireland.
Yeah,
of course.
So our next, this is quite something. The next one is Covidian, I can't even say it, Covidian Rhapsody. So here we go.
Mamma mia.
Aha.
So here's a little something for you. And it's all about the team. Let's keep up the spirits as together we battle COVID-19. Jackie, Paul, Ben, Nicola, Siobhan and Hazel, Jane, Elva, Helen, S and Daryl, Bish, Kath, Karen, Julie, Lindsay, Donna, Jamie, Rachel, Wendy, Amanda, Madison and Amy, Abby, Rebecca, Emma, Sarah, Shia, Sophie, Helen, Nate, Charlotte, and Clary. J-P-U-H, getting Larry, keeping us together as the world gets scary. J-P-U-H, you are all great. You can change fate. J-P-U-H, you are all great. You can change fate. J-P-U-H. Give me a J, give me a P, give me a U, give me an H. Say research. Say research. Give me a J, give me a P, give me a U, give me an H. I say research. I said research. In 2021 we need to be there for one another, to rest and help heal the world and then recover. Kick COVID to the floor, research what the world's been searching for. Now JPUH, who do we appreciate? Saving lives all the time, proving you are truly great. Be there for one another. There may be things you want to give up, but we should never give up on each other. Give me a J, give me a P, give me a U, give me an H. Say research. Say research. Give me a J, give me a P, give me a U, give me an H. I say research. I said research. So give it up for the JPUH crew. That's what they do. They bring hope when it feels hopeless. They keep on going when most will give in. On your shoulders we stand, JPUH crew. Thank you.
Wow. I love that. That's brilliant. That is great.
I'm so sorry Claire's not here for us to tease her.
I think she's currently
Is she
in
lurking?
a car somewhere just at the moment. So that is just fabulous.
I love it.
Some people are just so talented. I'm so jealous.
I know. I'm glad you didn't try to sing today.
Yeah. No, yeah, that's not a pretty
But you're
thing.
sharing your screen beautifully.
Oh, thank you so much.
People want the link. It's great. Good comments here. Kathy, Claire will be pleased.
Okay, so the next one is from my neck of the woods. It's from Edinburgh and from Lothian. So I shall share the screen here. And I shall start this one.
My name is Juliet MacArthur and I am the Chief Nurse for Research in NHS Lothian. Nurses and midwives are at the forefront of delivering care and conducting research. Through effective partnership between NHS Lothian and the University of Edinburgh, our research nurses and midwives work as part of a wider community of clinical teams, laboratory and technical staff, and research support and management to deliver pioneering clinical research that will improve the treatments we offer and the way we deliver care in the NHS today and tomorrow.
Before our midwives deliver a new life, the maternal and fetal health research team focus on solving global challenges that affect maternal and fetal health. At present, the team are leading projects in preeclampsia diagnosis, maternal and mental health, predicting preterm birth, and tissue biobank management. A short walk away, over at the Royal Hospital for Children and Young People, a specialist team of research nurses work flexibly with children and their families in recruiting to the national and international trials. The state-of-the-art hospital that was opened this year and boasts the best research space for children in the UK to deliver trials safely and in comfort. Across the NHS, there is an extensive range of research studies that people are invited to partake in. Our clinical research facility at the Western General Hospital, one of the first 5 funded in the UK and has expanded to 3 sites since opening in 1999, the focus is on keeping participants safe in the early phase of experimental medicine studies and to support investigators across any clinical specialty which does not have their own dedicated research nurses. They were the first NHS facility accredited by the MHRA to conduct phase 1 trials in the UK and advise other clinical research facilities nationally in this area. At the Princess Alexandra Eye Pavilion, Margaret provides support to trials looking at preventing sight loss and improving the lives of those with eye conditions. The research department was recently involved in an innovative international implant trial for glaucoma patients, as well as starting a gene therapy trial this month. The gastrointestinal research nursing team recruit into trials for treatments to improve the quality of life for those living with Crohn's disease and ulcerative colitis. Edinburgh has one of the highest known rates in the world of these conditions, with 1 in 125 people being affected. The diabetes research team are involved in a number of large-scale global trials, including a novel once-weekly insulin compound. Soon a life-changing study will start using the latest technology to benefit people with type 1 diabetes. Our cystic fibrosis research nurses work with cystic fibrosis patients from all over Scotland. The groundbreaking research trials that they undertake have contributed to new drugs being licensed, dramatically changing and prolonging the lives of those who suffer from this life-limiting genetic condition. The research nurses within the Regional Infectious Disease Unit trials cover a wide range of known and emerging clinical infections. Over the last 30 years they have worked on trials improving the treatment and preventing HIV. More recently the focus has been on the urgent public health studies on COVID-19, including trials of potential treatments and vaccines. Our extensive team of research nurses working in the Cancer Centre at the Western General Hospital pioneer how people are diagnosed and give them access to novel treatments including radiotherapy, chemotherapy and pain control. Cancer research undertaken in Edinburgh has improved the lives and outcomes for countless families in Scotland and the rest of the world. In the emergency department, a large team of research nurses work with those whose motto is "Powered by Curiosity," work on a variety of studies, trials and innovations. Patients' presentations at the ED encompass all medical specialties, so collaboration is at the heart of the eMERGE ethos. The Resuscitation Research Group focus on pre-hospital care. The team have been at the forefront of the Scottish Government's out-of-hospital cardiac arrest strategy and in driving improvements in bystander response to CPR across Scotland. The Cerebrovascular Research Team coordinate a diverse portfolio to expand our knowledge and treatment options in stroke, neurosurgery and interventional neuroradiology, from acute presentations to rehabilitation and secondary prevention. Our critical care research nurses work sensitively with sick patients and their families in the ICU, trialling new drugs, devices and learn about people's experience of care during a very difficult time in their life. The team also runs studies investigating anaesthetics and the ways patients are looked after during operations. The cardiology research nurses focus on diagnosis and treatment of heart valve disease, coronary artery disease, heart failure, hypertension and rhythm disorders. Saving lives and improving future care is the focus of their work, beating heartbreak forever. You may find our respiratory research nurses at outpatient clinics and on wards looking at new treatments and helping patients manage their conditions and lung diseases, such as bronchiectasis, COPD, interstitial lung disease, pneumonia and TB. The Anne Rowling Neurology Clinic nursing team work in a unique building where NHS teams review people and directly introduce research at routine NHS appointments. This clinic focuses on trials and studies and improvements to quality of life for those living with conditions such as MS, Parkinson's disease, dementia and motor neuron disease. The gift of life is precious. The Edinburgh Transplant Research Team drive forward changes in transplantation, whether it is improving the quality of the donated organs, new medicines to prevent organ rejection, new surgical techniques, or ways to deliver nursing care. And after death research legacy continues. Tracy and Chris facilitate post-mortem tissue donation for research, taking bereaved families through the process of authorisation following the death of their relative. The Edinburgh Brain Bank collects samples from people with a variety of conditions, contributing to a greater understanding of diseases such as MND, stroke and MS. Today is International Nurses Day. The research we carry out today will improve the care we deliver for you tomorrow and millions of pathways.
Very nice, Gordon.
Yeah, that's really, really nice. Yeah,
It's nice to see there at the children's hospitals opened.
Yeah, that took. Yeah, it was the building was finished some time ago, but they had some issues with, so they couldn't move in. So it was yeah, so it was great to see that they've actually now completely moved into the facility. So yes.
Yeah.
Marvelous. So I just need to. Could you just hold the fort just for a second, because I need to see if there's an email from if Emma Heron is Emma.
Emma's here.
Emma is here. Aye.
Do you see her?
Yes.
Okay.
Hello, I'm here.
There she
Hi,
is.
Emma.
Can you hear me?
Yes.
Hi. I have actually, yes, I've pre-recorded my talk. But the reason I pre-recorded it is because I live in rural Wales and the internet can be a bit dodgy. But of course, that's now meant that it's taking several hours to upload to YouTube. So I don't know if I can share my screen, Gordon. Would that be okay to give
Yeah,
my...
you should be able to, if you just go down to the bottom
Okay.
and click share screen, yeah.
I'll go ahead and do that then, if that's okay.
Thank you.
Okay, I'll just press play. Oh. Sorry, I might have to unshare, press play, then come back again. Sorry about this.
No problem.
Gordon, Claire's here. Could you make her co-host, please? I don't seem to be able to do that. If you click on her name,
yeah,
participant list.
Really happy to be joining you.
Oh, I like this. And maybe next year from Sweden, indeed. That was a nice comment.
Actually, but never mind. It is great to be with you this afternoon from Wales. And it's great to be with you on International Clinical Trials Day.
Emma, it's a wee bit clunky. Oh,
Yeah,
lost all the sound.
It's not very good, is it? Should we swap around?
Yeah, we can do that. Yep. Well, let's see.
And maybe, how long do you think it might take to download? I wonder, Emma. You're muted now. Let me ask you to unmute. Sorry.
Yeah, I'll have a look at how long it's going to take to download. I'll get back to you. Carry on with someone else.
Marvelous. Oops. Okay. So I'm just looking at the agenda there. So, okay, I could show Bernie's presentation just now, if that's okay.
That's great.
Grand, if you just give me a second.
Yeah, of course. Claire, you made it back. I'm unmuting you. There you are.
Hello, everyone. Sorry for the interlude.
It's been wonderful. You've missed some amazing things. And that video, oh my goodness, the pageant video, you guys are rock stars.
So I just was looking in the chat just now and someone says, who's Russ and Spoz? So Russ is my husband and Spoz is one of our best friends. So when the second wave hit sort of around Christmas time, everyone was really struggling at work. People were really tired and just really finding stuff tricky. So we spent the night before New Year's Eve pretty much all night. We just all stayed up trying to come up with something. It was really fun. So I thought it might be nice to share here.
It was really
Hopefully people liked it.
Everyone did. It was brilliant.
So I'm just trying to
I was listening in the car. I couldn't get the video or anything because obviously I was driving, but yeah.
I felt like I kept admitting you and you never seemed to appear on the list.
Sorry, yeah. I was trying to get into it Yeah. Anyway, I got it. I could hear everything.
Oh, that's good. I just want to ask you, the cadet scheme, is that the national program through the RCN or the Princess Trust, or is that just a scheme and you're calling it cadets?
Are you asking me?
Yeah.
Or
Did you have?
so
we
have got some. We have, but they're not research specific. But I think the problem with the cadet title is that there is no one scheme across the UK, and this is what I found out from doing that work. So it depends who you're speaking to as to what the connotations of cadet means.
Excellent, thank you, because there was something in Oxford that I wanted to follow up on, and I remember you did as well yesterday. Mentioned it.
I heard that they've got a research cadet, so I'm quite interested to hear more about that. So I might join you in finding out, actually.
And then rolling out.
Can I ask, are you saying the University Hospital Monkland's marvellous?
Yeah, yeah, we're done.
Good. Yeah, okay.
The Research and Development Department in NHS Lanarkshire is similar to the similar departments in other health boards in Scotland. The main role, although it does a lot of different things, the main role really is to provide better access to research studies for our patients. Through research studies, our patients are able to access new or cutting-edge treatments that they wouldn't otherwise be able to access out of the context of research. So that's a very important thing in terms of improving the quality of care that patients can access. And indeed, in some specialties like haematology, the majority of patients can only access the best care in the context of clinical trials. So it's a very important aspect of the offering of care that we have for the patients in Lanarkshire. There are a lot of research networks set up that we liaise with. Through collaborating with the universities, we are trying always to increase the amount of research that we're doing in collaboration with them. We also reach out on a more national basis to other research organisations and universities around about the UK. Scotland as a country has a very well coordinated research infrastructure. All of the boards cooperate very well with each other and with the Chief Scientist's Office. Across the UK, in fact, there was a very good response to the research response to the coronavirus pandemic. One of the first things that we did was try to mobilise as much of the research infrastructure as we possibly could to target specifically looking for treatments, therapies that would perhaps help people who had been infected with the virus. One of the things in Lanarkshire that is perhaps not the same everywhere, I know it's like this in some other organisations, but not necessarily across them all, is that we have a single R&D department. The trials nurses are part of the same department as I am in. We have trials pharmacy people who are part of the R&D department. So we are really one big team. It's quite a big health board, but it's quite a close-knit and well-integrated research team. Our research nurses are an excellent team. The majority of the research nurse team, those that weren't involved and still continuing with the crucial clinical trials that we had that were treating patients, were then focused on taking on some of the big national clinical trials that were running targeting COVID. So we became very quickly involved in the biggest clinical trial, the biggest COVID clinical trial in the world, which is the Oxford-led recovery trial. We recruited very successfully to that, and we became involved in a few other important, nationally important and globally important coronavirus research studies and clinical trials.
I've been a nurse since 2006, so I worked kind of in medical wards and stuff. And in the wards, you didn't always get the learning experience that you were always really busy, and it was all kind of time management and stuff. And although they did kind of diabetes research and stuff in the wards that I was in, it was just something that I wanted to expand on so that I would be able to learn more. enjoy meeting people. So the biggest thing for me is you're able to speak to people.
For the previous 3 years, I was working in a respiratory ward as a staff nurse, and I saw firsthand the kind of devastation that COVID was having on patients and families and so on. And it was really heartbreaking to see. And I just really wanted to do something to kind of get ahead of this and do something that, you know, could make a difference before it starts impacting people.
What specifically about research nursing appealed to you?
I think really the whole variety of it. Obviously at the minute we're focused on COVID, but now the other studies are starting to open up, and there's just so many things you could be doing. So one day you could be looking at a replacement to the PCR test, the next day you could be looking at different ways of detecting heart disease and related conditions. So it's constantly changing and evolving, and it just keeps it interesting.
Where do you see the future of research nursing?
I think COVID obviously has been devastating for everybody. It's had a large impact in the NHS and stuff, but I think some positives come out of it, that it has made people more aware about research. I was actually looking up with the vaccine clinics as well, and obviously they were asking the question, would you like to be contacted in research, and a lot of people were saying yes.
One of the things that came out of the RCN conference last week was how much the research nurses felt they'd been able to improve their relationships with wards and so on, becoming more embedded in wards and having a wider appreciation of what we do as research nurses. So I think that's the way forward, to kind of build on those relationships and make research not something that's specialised and away from everything else, but something that's seen as part of the whole spectrum of nursing.
The Siren Studies, a UK-wide study looking at immune response in healthcare workers to SARS-CoV-2 infection. The main aim is to investigate whether antibodies provide a protective effect for subsequent infection. Scotland, England, Northern Ireland and Wales are all participating. We've recently finished recruiting in Siren, and there's now over 44,000 participants throughout the UK. NHS Lanarkshire were actually ended up the third highest recruiters throughout the whole of the United Kingdom, which is an enormous effort considering they started a wee bit later in terms of recruitment, and we've got over 1,000 participants from NHS Lanarkshire alone taking part in Siren. Scotland's providing 14% of the total Siren participants, and we've over 6,000 healthcare workers taking part. There was a real huge effort within Scotland to recruit our participants, and we're delighted to have a couple of the nurses that were involved in the recruitment process here with us today. Karen, you played a really important role in Siren in Lanarkshire. Can you tell us a wee bit about what specifically you did during the study?
Okay, so as a coordinator of the study, my role was to facilitate the set up of the study and to help with the PI to ensure that all processes were in place and that all staff had met the study requirements for training as well. I would also say that I am the principal contact between the Public Health England and the study monitors, so any issues going forward of that, then they liaise with me and I try my best to sort it out as well. In the end, we ended up, because of the volume of interest from staff and we wanted to accommodate them, we ended up having to put all members of our research team on Siren study and to see all these participants. So it was just, we just threw everything at it. We were busy days, staff managed, and we managed to accommodate nearly all participants that were interested in taking part.
So Maureen, can you tell us a wee bit about your role in the Siren study?
So part of my role was mostly administration. So I was developing spreadsheets, I was making up appointment calendars, I was locating all the results for the participants that we had, and we were manually sending them out by email. So initially this started off that there was just myself and a colleague, and we were maybe doing it for half a day each. but quite quickly we realised that this had, grown arms and legs. And it was great because so many people wanted appointments, and we had actually 4 people working on the appointment making at one point. Everyone would just see when they got an appointment, especially at the end, Sally, they were so excited. It was like they had actually won a watch. So it was great because we'd obviously were running out of appointments. We had more people than we actually could recruit because of our end date, the 31st of March. And so when they got, they're like, oh my goodness, that's great. I can't, So also, I thought, see when they realised that this is 12 months, which they did because we'd obviously spoken to them about that, and then the 2 weekly PCRs. So they were getting to know their COVID status every 2 weeks.
Being organised was probably one of the most important parts of the study, because if you weren't organised, you kind of failed straight away. As I said, the visits were very simple and straightforward, but it was just in terms of making sure that we had all the stock that we required. So with outsourcing stock for that, looking at accommodation, looking at ensuring that staff were familiar with the study and could carry out the visits as well. I think initially we were quite naive in how much stock we would need. We went from ordering in the hundreds to then ordering in the thousands, and to the point that NHS couldn't even supply us anymore, so we had to outsource things like the siren labels that help labs identify the siren samples. We then in the end up had to order 110,000 labels, so it was massive. So, and again, just having places to store all this equipment as well, so it was just humongous. We are just constantly adapting our processes and changing just to meet the demands and how we work. And now that recruitment has ended, we've got a wee bit more time just to kind of step back and look and see how we can do things better. Whereas initially it was just recruit, and that we couldn't even lift our heads up. It was constantly from that.
So Maureen, you and I have been in contact quite regularly because you've been identifying some issues in the administration of the project. And just to flag things up to us in terms of the protocol, make sure that everything's going correctly, but also inform us of progress within Lanarkshire. So that's been a big part of it, and I do think people think studies like this, it sounds relatively simple, like fortnightly visits and monthly bloods. Actually, there's such an enormous administrative role in the back.
Every day it was something new, but it's been very, very enjoyable, and it has been, the participants are just been so happy to take part. It's been a joy. It was very, very busy. Karen, I was in communication with every day. I think maybe 10 times a day, just till we ironed out various issues that we had. But it was a role that certainly developed, but mostly administrative, mostly dealing with spreadsheets, mostly dealing with blood results, and being the person that the participants contacted, as well as myself having to contact you, Sally, when we needed a bit more confirmation.
Absolutely, and I think again having the well coordinated administration for the clinical teams who are so busy at this time as well is a huge thing, and encouraging them to continue taking part. So it's not to be underestimated, the coordination of visits and things like that. So Maureen, you've mentioned quite a lot of contact with participants. What do you think participants have got out of taking part in Siren?
I think they've just been really happy to think that they can contribute. I mean, we've all had this year of, they've been working in the wards, they've seen the horrible effects of COVID, and now they're all thinking, there's actually something that we could do. So there's that kind of altruistic part where they want to do something good and they know that it's contributing to give us a better picture. Overall, people just want to make a contribution and are just so happy to be taking part in the trial. It was really good for us all because it was a real, boost, and we were all working hard, we were working long hours. The girls on the ground they were extending their hours, they were starting earlier to accommodate people, they were working later. Some people were fitting in colleagues in their lunch breaks. So it was just that feeling that everybody was trying to get the best out of it, and we're just really happy with the way that everything is going.
Every single test is a contribution to the body of knowledge to help manage the pandemic in future. So,
and I think we consciously as a team, when we have contact now, we're thanking people for participating, because as the time goes on, it is 12 months is a long time to keep people engaged, but we're constantly saying thanks very much, because this is a very important study. We appreciate your contribution, and hopefully that is keeping people motivated to come back, because obviously we want to retain as many as we can.
And I think that's really where your role's so important to the study in general, because it's really personal relationships, you know, it's making people feel comfortable, welcome, part of that group. So we're so appreciative of the work that you guys all have done for us.
We've been trying to make it quite simple for participants. So as I say, we've got this other data system called Salus that we use, and that electronically sends out the results. So I think, you know, people are quite engaged with that they are getting a very, very quick result. You can actually feel as if you get to know people a lot better than you did before from all over.
And it really has been a whole health board.
As you say, it has been kind of, you know, all the nurses, it's been kind of like a family, because you're more or less speaking to them all day, whereas normally you would just be, you know, in your own area, but now we've all had to communicate. I think it's been a great thing for us, definitely, and all the participants.
I would urge other boards to try to look at other health organisations, rather to try to take advantage of the integration that will doubtless have improved in everybody's organisation during this by necessity, because if anything, in terms of research, this pandemic has shown how important it is. Without the clinical trials that have been carried out in neighbouring boards, for instance, the vaccination trials, that has really highlighted the importance of research. We really don't want to, as a research community, lose that profile. So hopefully we will come out of the pandemic, and hopefully research more generally will benefit from some of the advances that we've saw in processes and integration.
Marvellous. Thank you very much to NHS Lanarkshire. Let me see if my screen's a wee bit odd, so let's see if I can, stop share. Marvellous. So I think we were scheduled, Claire, to have a break now, so should we just go to that and see if Emma can...
Yes, please. Yep, and then Emma can come back in. I'm just speaking to her outside of this at the minute. We're just trying to sort it out. We're going to see if we can send it over via WeTransfer to you, Gordon.
Okay, no problem at all.
For the next, and then Emma can be in the next session.
Grand. So I'll just stop the recording just now. Stop the recording.